Welcome to Keeping an Eye on Dry Eye Disease. My name is Dr. Daniel Gagnon and I am joined by Dr. Johanna Korimis, and we will be discussing the dry eye disease. To introduce myself, I am a family physician practicing in Montreal. I am joined by my colleague, Dr. Korimis, who is an ophthalmologist specializing in the cornea and anterior segment disease. She completed her medical degree with a U-Brock scholarship, followed by a residency at McGill University. She then completed her fellowship at Tufts University in Boston with an E.A. Baker scholarship. Following this, she returned to Montreal and has since worked at the University of Montreal Hôpital Maisonneuve-Rosemont and at McGill-affiliated Jewish General Hospital. Thank you for joining me, Dr. Korimis.
Thank you for having me.
We are here today to discuss the importance of recognizing, screening, and treating the dry eye disease. More than a mere symptoms, DAD can be progressive and bothersome, with impacts on the quality of life and on vision if left untreated. We hope to bring physicians up to date in the identification and management of the dry eye disease. To start, Dr. Korimis, what is the dry eye disease?
So dry eye disease, or DED, was redefined in 2017 at the Tear Film and Ocular Surface Society International Dry Eye Workshop 2, TFOS, what we call DOOS 2. And it was a very complicated definition, but basically a multifactorial disease of the ocular surface, which is characterized by a loss of homeostasis of the tear film and accompanied by ocular symptoms in which you have also tear film instability, hyperosmolarity, ocular surface inflammation and damage, and also neurosensory abnormalities, which can play etiologic roles. Although this is a complicated definition, really in your day-to-day practice, you just have to listen to your patient's symptoms, looking for some classic symptoms of dry eye disease, such as burning, irritation, sandy feeling, blurry, fluctuating vision, especially with activities on screens, TVs, computers. Patients also complain a lot of reflex tearing. Those are all sort of symptoms that we hear from patients.
What are the most common presentation of the dry eye disease?
So I mentioned a few just now, but basically burning, redness, irritation, feeling something in your eye, foreign body sensation, sandy feeling, tired eyes, itchiness. You can also get some photophobia or light sensitivity. You can have blurry vision with computer work or any kind of screen work. Anytime you're staring at something, you blink less, so the blink rate goes down and patients can have blurry vision. Reflex tearing, fluctuation in the vision, worsening of symptoms at the end of the day, especially if you don't have enough tear production. There's also the evaporative dry eye disease, which is sometimes worse in the morning, and you have like sticky lids in the morning. Contact lens intolerance, all those are things that you hear from patients very frequently.
How serious is dry eye disease?
So dry eye disease, if left untreated, the nature of the disease actually worsens. So patients will get worse with time, and when we grade the disease, it actually does worsen with time. It's been shown in studies. And the patients risk having a decreased quality of life because of the blurry fluctuating vision, because of the discomfort. Also, you can have a higher risk of corneal ulcers, which can be very detrimental to the vision if you get a scar, or you can sometimes have more serious infections that are hard to get rid of. So it can be vision threatening for sure.
Who is at risk of dry eye disease?
So there's a long list of risk factors. The main ones I would say are older age and female. So women that are postmenopausal is a classic dry eye patient. Environmental factors. So if you live in a very dry environment like Texas, you'd have more dry eyes. If you're in a humid environment, it would be certainly more comfortable for dry eye patients. Other things are being on screens or devices for a long time. Like we tend to blink a lot less when we're looking at a screen. So the blink rate goes down and people evaporate their tears more and they feel the dryness a lot more. So screen time is another big one. Other things that are noteworthy would be contact lens wearers, hormonal changes, as I mentioned, postmenopause, but any hormonal changes, hormone therapy, Asian descent, smokers. Those are some of the main ones I would say.
Which condition or medication predispose a patient to dry eye disease?
So there's a whole list of them. If we start first with autoimmune diseases, which is a very common one, so thyroid disease, diabetes, rheumatoid arthritis, Sjogren's, even GVHD, so graft versus host disease, which is more rare, but would be in that category. Rosacea, psychiatric disorders, certain medications like antidepressants or antihistamines. And lastly, ocular conditions, which can be things like glaucoma, meibomian gland dysfunction, pterygiums, anything irregular on the surface, any recent ocular surgery like LASIK, for example, in young patients, or any kind of surgery really. And lastly, exposure. So if your eyes don't close properly, or you have any lid disorders like a seventh nerve palsy or blepharoplasty, where your eyes don't close properly, you can have a faster evaporation, and that can cause some exacerbations as well.
Why should the primary care physician screen for the dry eye disease?
I feel primary care physicians should screen for dry eye disease only because it's very common. It's about 29% of Canadians in some studies, and it has been shown to reduce quality of life of patients and correlate with anxiety and depression. Also, dry eyes can lead to patient frustration, increased risk of infections of the cornea, which I mentioned earlier, which can be sight-threatening because of scars, and sometimes even regular corneal ulcers, we can't seem to get a hold of them, and really we need to do, surgery like corneal transplants to get rid of ulcers, which can be very serious. And also, if they're left untreated, the disease actually worsens with time, so the dryness will get worse. Also, early diagnosis can prevent this worsening of the signs and symptoms for the patient.
And how can the primary care physician screen for this condition?
There are many ways somebody can screen for the condition. One way is having pamphlets in the office, in the waiting room, educating patients about dry eyes. You can have a nurse handout questionnaire, so there's all kinds of dry eye questionnaires that you can get. And if they have certain risk factors on their history, so when you question the patient with their history, their medications, you can take note or have it in your mind. And simply just asking patients how their eyes are doing. That simple question, they might mention that their eyes are burning at night, or they're tearing, or so on. Patients, I think, are very forthcoming to mention when they have problems with their eyes. Some of the validated questionnaires that you can look for are the SPEED, S-P-E-E-D, or the DEQ5 questionnaires, which are very easy and simple. The DEQ5 is really a series of 5 short questions. And other things that family physicians should do, as always, obviously, is take a good history, looking for the risk factors, being aware of the medications that can exacerbate the symptoms, and potentially give alternative drugs if there are some that could help the patient.
As a primary care physician, I need to know how to assess the severity of the condition and when I should refer my patient to a specialist.
So the severity can be judged by the score on the questionnaire if you're using a questionnaire. If you're not using a questionnaire, you could just try to assess how much the symptoms are impacting the patient's life from day-to-day life. And while the basic treatments usually start with lubricants, and which means artificial tears or gels at bedtime, the next steps would include some anti-inflammatory, so some further medication. Lifestyle changes can also be implemented. Things like a humidifier at home, especially in the winter, in our cold winters in the house, a humidifier is helpful. Reducing screen time if they're able to do that. And then if lubricants and lifestyle changes aren't really helping, it's probably time to consult an eye care professional. And it's crucial to remember that steroid drops, which eye care professionals use a lot, can give intraocular pressure spikes and cataracts. And so it's important to be able to take the pressure in the office if you're going to be doing that. So that's why we don't really recommend that primary care physicians be giving steroid drops, because they don't have access to a tonometer in their office usually.
Why should we use a questionnaire when diagnosing the condition?
I mean, it's not just for diagnosing. To diagnose really dry eyes, obviously you have to do a slit lamp exam as well, but it'll give you sort of a hint that the patient is suffering from dry eyes. And the questionnaire, I find, helps patients sort of see that they're getting better. So sometimes they don't realize they're getting better because it's gradual, and by doing the questionnaire before and after treatment, they can see that they've been helped, and so that'll prove to them that the medication or whatever they're using is helping. It also shows the physician, because you forget how the patient was feeling before by just writing burning and stuff like that. There's no actual objective measurement. Yeah.
What role can the primary care physician play in the treatment of the patient with the dry eye disease?
So we've mentioned a few things. So besides screening and trying to figure out who has dry eye disease, things that you can easily do are lifestyle changes. So we mentioned a humidifier earlier, reducing contact lens wear if they can, and stressing the importance of contact lens hygiene if you can, controlling allergens in the environment, quitting smoking, avoiding secondhand smoke as well, limiting their screen time, also eating healthy. So omega-3 has been shown to help. However, there's recent studies that show that it's a little less helpful, but still, having a good diet is always helpful. Also helping them choose artificial tears. So patients tend to go into the pharmacy and take the cheapest artificial tear, which is not great because the less expensive tears often have preservatives that are very irritating and eventually cause harm to the surface of the eye. So it's important not to go for the cheapest lubricant. So maybe recommend some brands that you like. Also, you can counsel patients to use the tears during the day regularly. Some patients tend to use them only when they have the burning, so it's important to use them regularly, to use an ointment at bedtime, which can be helpful overnight. Hot compresses are another easy thing that you can recommend to patients. You can buy a mask, a heating mask in the microwave at the pharmacy and, do like 10 minutes twice a day or 5-10 minutes twice a day over the lids, and that can help the little oil glands sort of secrete better quality tear oil layer, I should say. And I mention that because there's kind of two types of dry eye disease in our mind. So we have the evaporative, which is mostly the oily layer, and the insufficient tear production, which is coming from the lacrimal gland. So we have those two sort of segments that we can try to help. So with the lubricants and the hot compresses, which is another thing we use for styes, as you know. So it's important to ask them how often they're using their tears. Make sure they're using them frequent enough. If they're not using them, if it's not enough, then have them increase the frequency. If they're using something more than 6-8 times a day, some people say 6, some people say 8, it's best to use something preservative-free, because the preservatives, even if they're good quality preservatives, can irritate after a certain point. And then just to refer to an eye care professional when it's not enough, when those things that you're suggesting to the patient are not enough. Refer to an eye care professional if their symptoms are really disturbing their daily activities and they're very unhappy or they're very bothered by their symptoms. And if they're complaining, of course, of decreased vision, that's always a red flag. So if they're having problems seeing, it's not it may not even be dry eyes, who knows. If they have any pain that's acute or constant, any alarming symptoms that might ring to you like it's a little unusual. Once they've started the treatment with the eye care professional, of course, you can ask them how it's going with time and make sure that they're well taken care of. Sometimes patients are still having a lot of problems and they can't get through to the eye care professional or whatnot. So, you can always have a secretary call the office and see, if they can be seen more, in a faster follow-up if they're still having lots of problems. So another thing I'd like to mention is that, all these lubricants and hot compresses are really a Band-Aid solution. We're not really treating the underlying problem, which is inflammation. And so this is why often the eye care professional will prescribe an anti-inflammatory, a steroid, or an immune suppressant of some sort. There are some that will act very quickly in a few weeks, others that take a month or two to really get going. So just be aware that these patients really have to come back several times, and we really have to find the recipe that works for them. So everybody's a bit different, and we have to kind of play with different lubricants, different medications to try and find what works for them. So one thing that might really work for one patient may not work at all for another patient. And so patients have to be patient, and the physician has to see them several times to try and find something that works for them. And although steroids are quick to help, we don't use them long term. We usually tend to use them for short periods of time. Rarely we use them long-term for very severe cases, only because, as I mentioned earlier, they can cause high pressures and cataracts. So we have to monitor those side effects as we treat the patients.
Thank you for answering my question on the dry eye disease, Dr. Korimis. This has been a great discussion. My name is Dr. Gagnon, and thank you for joining this discussion, and we will see you next time.
Thank you so much for having me. It was great. The views, information, and opinions expressed in this podcast are solely those of individuals involved and do not represent those of MD Briefcase or companies that support educational programming on MD Briefcase. This podcast does not constitute medical advice and is only meant to educate and inform the listener. This podcast is available at www.mdbriefcase.com and has been developed by MD Briefcase, supported by an unrestricted educational grant from Shire Pharmaceuticals.